It's my absolute pleasure today, along with Scott, to be moderating this session. Thoralf Sundt, who many of you probably have at least read much of his work, is the Churchill Professor of Surgery at Harvard Medical School. He's the Chief of the Division of Cardiac Surgery at Mass General Hospital and Mass General Brigham System Director for the Cardiac Surgical Program. At MGH, he's assembled a team of surgeons and support staff, and as many of you would be aware, Kenny Shan is the Chief of his perfusion team. And together they've grown the clinical practice to be the largest in New England. Dr. Sundt's clinical focus has been on surgery for the correction of acquired cardiovascular conditions in adults, and his research interests are very broad, but have ranged from organ transplantation to the disciplines of human factors and systems engineering to improve the safety and efficiency of healthcare delivery. Dr. Sundt is also the past president of the American Association for Thoracic Surgery and was president when Kenny Shan was president, and they co-chaired the very successful combined meeting we had in Boston in 2017. Today he's going to talk to us about building a high reliability team and the importance of community and collaboration. I wish you to welcome Dr. Sundt.
Thank you very much. Boy, the light just shines. You can't see in the audience there. Well, it's a real pleasure to be here and an honor to have you invite me to give this talk. I will say I worry a little bit that when you start getting invited to give keynote lectures, that means you're at the end of your career, but that's probably true. We want to talk about, for a little bit, about building a high reliability team and the importance of community and collaboration, which is ties in with your themes. No financial disclosures, as any investigator in this area knows, sadly. There's not much industry support for financial support for exploration of these topics because there's not really an industry product. So those of you who know me know a couple of things. One, I'm team focused. You'll notice that yes, Kenny is not here, so that is a picture of the Patriots in the corner and not a picture of the New York Giants. But I think that the Patriots way also exemplifies many of the topics that I would think are important about teamwork. Certainly we're a team, we have to be a team. And I want to talk a little bit about things that I've learned from Amy Edmondson, who's a Harvard Business School professor, a very thoughtful investigator. She's spent a fair bit of time looking at cardiac surgery and teams and teaming. And she talks about teaming as a verb, not as a noun. I added the little Bill Belichick quote there. He's famous for saying it's not about collecting talent, it's about building a team, and that really is the focus, although I still can't understand why he didn't play Malcolm Butler against the Eagles, and that cost me $100 in a bet with Joe Bavaria. So the surgeon perfusionist team, I think, is special, and I realize we've got a widely disparate demographic here. Those who are as old as I am will remember that the original perfusionists were actually surgeons. In fact, the first perfusionist at the Mass General Hospital was Jerry Austin, who's pictured there with his pump from a Time magazine article, I believe. And the relationship between perfusionists and surgeons has evolved over time. Like any intimate relationship, some are good, some are problematic. But I think there's no doubt that the relationship between surgeons and perfusionists is a unique one. And certainly, I regard Kenny as my eyes and ears in the operating room. I can trust that Kenny will let me know if he's got a concern. You might look at this, you might be aware of that. It's good to have your eyes and ears there. Well, I want to talk a little bit about my journey, not as Oprah says, enough about you, let's talk about me. So let's talk about me. My journey from Boston to St. Louis to Rochester, Minnesota, and back to Boston again. So I've practiced cardiac surgery in a variety of locations. I spent a year and a half in the UK as well after my training in St. Louis. And over the course of that geographic journey, I've also had an intellectual journey or a cognitive journey from what has been described as the traditional medical perspective to the systems perspective. And this is a really fundamental and important concept, I think. And it's one that I don't know that everyone who needs to understand it and appreciate it always does. We as surgeons, certainly, and I'm going to be hopefully as transparent as I can about surgeons, tend to think that the result of the product of the operation, the outcome of the operation, is principally, frankly, dependent on us, how well we do the operation. And there's no doubt that's a big component to it. If you mess up the operation, that's trouble, as you all know. But there's so many other factors in the system that impact it. And the implication of that is not just that lots of stuff goes into the outcomes, which you'll hear surgeons complain about, the intensivist, the this, the that, something or other else. But that means, the implication of that is that if you want to optimize the outcome for your patients, you need to embrace all those members of the team. You need to understand that it's your job to support that team and to make correct those system factors, and that's how I spend much of my time. And I hope an important message to all of you is engagement. We need your engagement. You are a critical component of that team. We need you to step up. We need you to participate. The way I was trained in St. Louis, it was, up, down, on, and off. Those were the instructions that went back and forth between the surgeon and the perfusionist. And there might be some folks with his hair as gray as mine, or as little as mine, or as disappearing as mine, who will remember those days. All I want to hear from the perfusionist is on, off, up, and down. That's nuts. That's crazy. And we've got to be honest that that's sort of the culture that we're emerging from. Now, when I was at Mayo in Rochester, I had a case that some of you may have heard me talk about this case before, but I apologize for that if it's redundant, but it had a profound impact on me, and it was a surgical error, and it was a teamwork error. A 56-year-old man who'd had a huge MI wound up with a left ventricular assist device, waiting for a heart transplant, 3 months, 4 months in the hospital, and on Christmas Day, a heart became available. I don't do a lot of VAD work. I had a second surgeon in the room. The two of us did the operation. We're people who are experienced in doing heart transplantation, and at the end of the case, we got upstairs, and the perfusionists said to the nurses, I subsequently found out, this is not going to be good. Couldn't figure out what, I could tell there was a subtext going on, but I wasn't quite sure what was happening until the next day when we did a CT scan, because he didn't wake up, and this is what his head looked like. And we had pumped his head full of air. And the point I want to make is that someone else in the room knew that we were making, as surgeons, were making a mistake. Someone else knew and didn't feel comfortable speaking up. That is a problem. That is a problem. And I took it as my responsibility then, and continue to take it as my responsibility to establish an environment, a culture where people do speak up. And I've spent the last 20 years writing about that and talking about that to anybody who will listen, because this shouldn't happen, right? Led to a lot of study of human factors, all kinds of things. You may not be able to read the last of those panels, but you may be interested to know that we even did a human factors analysis of cardiopulmonary bypass machines. We tried to get one of the companies interested in building a bypass pump in the same way that Boeing, at least the Boeing of old, that Boeing built the cockpit for a 777, which was a user interface focused, a human factors design, right? That didn't actually go very far. But the point is, the key to this all is effective teamwork. We've got to understand that that's the most important thing that we can do, is emphasize teamwork. The rest of it is just how we get there. But this is the objective, teamwork, real teamwork. Now, this is part of of Amy Edmondson's argument that a team is not a work group. The classic definition of a team is it's got a defined structure, it's got defined roles and responsibilities, a clear and common goal. And yes, Donnie, familiarity does help, but familiarity is not the whole thing. Familiarity with one another means you might understand each other, you might predict each other, you might understand what one another's weaknesses are, but it's not quite the same as being a team, an effective team, a resilient team. Amy talks about it being a verb. The classic example, team, is a noun. She talks about teaming as an active process, and that's what's required in a dynamic environment. It requires a culture of active collaboration. And the fact is, and she even points this out in her book, that in healthcare today, teams are dynamic. You're not going to always do every case with the same group of people. Yeah, it's more fun if you're familiar with each other. It's easier if you're familiar with each other. But when you need a team the most, when that aortic dissection comes in at 2 o'clock in the morning, you're not going to be with your familiar team. So relying on familiarity doesn't make any sense. You've got to rely on active teaming. Teaming requires, and this is part of why it's a challenge, especially for control freaks like surgeons, teaming requires relinquishing control. You've got to relinquish control as the objective in favor of establishing adaptive capabilities as an organizational competence. It's a shift in focus. Not I've got control of everything, but I need to build a team that has adaptive capabilities and organizational competence. Edmondson frames it as a learning process, and that's got some use to it. She talks about communication, decision-making, action, reflection, those essential components that you need to regard this as a learning process. The result is a synergy, a resilient team able to develop solutions to complex and novel problems. I would argue, and here's a connection to your theme, a community. It's got to be a community with meaningful, real interactions where people are comfortable interacting with each other. It's not a collection, it's a community. And what is the difference? And I realize I'm standing between you and lunch, so I'm looking at my watch, that over lunch you'll talk about what is the difference between a collection of people and a community. What's the difference between a work group and a really resilient team, a really effective team? A slight digression, apologies to Nick for a prior debate that I had with him in this about a decade ago, where we debated checklists. And I do believe that checklists have a place. And I'll tell you, when we went to Rwanda to do some cardiac surgery, and I tried to go on pump with perfusionists from another hospital, and they didn't have our checklist that Kenny Shan has developed, I was very anxious. I was paralyzed. I said, well, what about the checklist? And they said, what checklist? I said, somebody get me the checklist. I can't go on bypass, I can't come off bypass without that checklist. A perfect time for a checklist. Stop everything, turn off the music. Are we all present? Have we done all these things? Going on and coming off bypass, perfect time for a checklist. But checklists aren't everything, and checklists are only useful to prevent errors that are actually on the checklist. It's like driving through the rearview mirror to some extent. So checklists are of value, but in a world of complexity, chaos, and what are called normal accidents, it doesn't solve all the problems. The complexity of cardiac surgery today, and again, these are quotes that come right out of Amy's book, the demands of subspecialization and multidisciplinary teams. You just were hearing about, from a cardiologist, about structural heart work. I mean, look at the way our field has changed. It demands subspecialization. Not just a cardiac surgeon or adult cardiac surgeon, requires a valve surgeon or an aortic surgeon, et cetera, so on and so forth. And it's characterized by unpredictable stuff, right? I mean, we all see this. It's unpredictable stuff. How in the world could that happen, right? This is what Charles Perrow talks about as normal accidents anytime you have a complex system. You've got to expect that. And those problems require creative problem solving. Creative problem solving requires cognitive synergy. High reliability organizations, and you may all be familiar with this, Kathleen Sutcliffe and Carl Weick from Michigan described this. High reliability organizations are organizations that consistently avoid catastrophes in an environment where normal accidents can be expected due to complexity, and I would argue that is cardiac surgery. And you'll see that little triangle, that's Robert Helmrich's construct. It's not just about avoiding errors, that's what checklists are for, but it's also about trapping errors and mitigating errors, and that's where you need the team. A checklist won't do it. A real team has to do that. Organized to expect, recognize, and contain the unexpected. Now, I should be at the University of Michigan, Donnie, maybe you can get me a job there. I'm a big fan of Scott Page is also at the University of Michigan, and he's written a terrific book about the power of diversity, and he actually does the math associated with it to prove the actual value of diversity. But the way I think of it is, if you have, and he's got examples in the book, if you have really outstanding teams, groups of people who are of the same discipline, non-diverse teams, and give them a problem to solve, may come up with different, each group may come up with a different solution to the problem, what he calls a local optimum, an optimum solution to it. But if you put together a diverse team with diverse perspectives, diverse expectations, diverse backgrounds, they will synergize and come up with a better solution than any of those subspecialty teams would have, and that none of them alone would have, right? That's what lateral thinking is. When you're sitting in a place, and what I hope will happen in some of this, it's the reason why we're having a physical conference in person, right? It's the reason we're here and not on Zoom, is so that we can interact. Something happens when you interact. Something happens when you argue with one another, when you try something out. I don't know, it doesn't look that way to me. That can only happen with an interaction, a community that's really interacting in a meaningful way. That's why you're here physically. Characteristics of high reliability organizations: preoccupation with failure. They treat lapses as symptoms. They're reluctant to simplify interactions. They deliberately nuance the interpretation of things. They're sensitive to operations. In other words, they're looking for hints, latent failures. Deference to expertise, that's important. When I talk about this oftentimes, I'll say that when there's a problem with the venous drainage, you are the experts. You're the ones that are telling me there's a problem with the venous drainage. I've got to figure out why I shoved the IVC cannula in the hepatic veins. I may have to solve it, but you're the expert on drainage and flow and DO2 and so on and so forth. You are the experts about whether or not you're pumping that patient adequately. And I think, and we've developed a culture with Kenny, where we get that feedback. So our perfusionists tell us what the DO2 is after we go on bypass. And they complain to us if they're not happy with it. And a commitment to resilience. High reliability organizations are committed to resilience. So how do we make it happen? And I'll try to be quick so that we've got enough time for some discussion. In my opinion, we focus on culture. People throw this around, oh yeah, culture eats strategy for breakfast, we all know that, and so on and so forth. But how often do we actually focus on culture with intent? How often do we really think about our culture? How often do we think about what's required to change the culture? Edgar Schein would argue that culture is based on a set of values, both espoused and assumed. So it's not just the values that we talk about. You've actually got to get into a deep discussion with somebody about, well, what are the values that you just think are so obvious, it's not even up for debate. It's obvious. Well, I may have a completely different set of these assumed values. And only through conversation, only through a meaningful interaction can we get into those. So it's a set of values. Culture is a set of values. And I think that you have to be explicit about it. If you're going to change the culture, you need to be explicit about those values, even the ones that you think are so obvious you don't need to state them. Like the needs of the patient come first. which I've unabashedly stolen from the Mayo Clinic and intend to continue to do so. Culture is reflected in behaviors, observable behaviors. So as a manager, if I've got to want to change the culture and I see someone whose behaviors are inconsistent with that, I can talk to them about those behaviors. It's harder for me to talk to them about those values. I should connect them to the values, but my focus is on those behaviors. And it's reinforced through things called artifacts. Now, what values are fundamental? Willingness to relinquish control, embracing collective effort, focus on adaptability as a competence, and sacrificing autonomy for collaboration. Those are the values that are required to have effective teaming and teamwork. For Amy, it's embracing a learning environment. She likes that it shifts the focus from a competitive one to a collaborative one, because learning is a collaborative activity. So in your brain, you're less likely to be thinking about winning and losing and start thinking more about problem solving. Conflict will arise in any complex environment. I think we have to accept that. The question is, how do we manage that conflict, right? This is a challenge, again, for task-oriented people, and most cardiac surgeons are task-oriented people. And I submit that likely when you're at 28 degrees, you want your cardiac surgeon to be task-focused, thinking about where those stitches need to go. But that's where we tend to feel most comfortable. We are better off telling. We're more comfortable in the lower right corner, telling, controlling. Less comfortable in the asking, the community piece, at least most of us, I think. So it's something we need to work on. It's not a sin. I'm very task-oriented. And it's not a sin. I'm not embarrassed by it. I just need to recognize it. I need to understand it and manage it. What behaviors drive teaming? Per Edmondson, item number 1 that she calls out is just what I told you about that patient at Mayo, speaking up. Honest, direct conversation, asking questions and seeking feedback. Now, I realize that not everyone in this room is in a positional authority. And not everyone has positional authority. You're not all chiefs of something, right? But I do think that you're all leaders and you're all members of the team, and your engagement is important, and what you think and what you do and what you observe is important. And so I would encourage you, again, maybe at lunch, we're talking to your senior mentors, how to initiate those conversations in a way with maybe a surgeon who doesn't recognize the things that I've just talked about. How can you help to enlighten them, not fight with them, but help them to see what the benefit is there? Honest, direct, not confrontational, not angry, but honest, direct conversation. Ask for feedback. You ask for feedback, they'll want feedback. Collaboration. Again, this comes from Amy. Experimentation, reflection. For me, it's about mutual respect, and it's about, as I've said probably too many times already, community. Mutual respect. You deserve mutual respect, as do the surgeons. Don't dismiss one another as difficult to work with and so on and so forth. Start with a foundation of mutual respect, have direct, honest conversations, seek and give feedback, and change the culture. Now, I'm just going to talk just for a few minutes about a survey that was done. This is published in the Annals of Thoracic Surgery, a survey that a pre-medical student did with one of our School of Public Health investigators about the culture. She was observing us as if she was sort of doing her imitation of Jane Goodall, looking at the chimpanzees. This precedes Donnie's varsity study. And they observed leadership functions. I know you can't read all of these things, but the point is that they went through a rigorous process. They defined different behaviors, and a couple that turned out to be most important: engagement facilitator. So there were things that we did that they classified as an engagement facilitator. Consultation, collaboration, inquiry, helping, supportive, apology, thank you. Positive valences, they're shown. Elucidator, that's teaching. I work in an academic environment, a teaching environment, but it's all about teaching, really, everyone on the team. And she she paired this with an evaluation, just not a terribly scientific evaluation, but they just asked members of the team, how would you rank these surgeons as leaders? We all want to be leaders. And then she correlated how we were perceived by them as leaders with these functions. And what they found with a high degree of a p-value was that low performers, yeah, they spent a lot of time teaching elucidators. They actually spent more time elucidating than the high performers, but the engagement facilitator was hugely different. The low performers did not invite engagement. The high performers invited engagement. I would say that's about teamwork. The high performers led teams. I mentioned something about artifacts. What do I mean by artifacts? An example of artifacts is the way that we do our briefings. The briefing tool that Kenny developed, and we could talk about how it was developed and so on and so forth. We do it in person, in the operating room. And I don't know that you can see this, but each member of the team has a role to play. So the circulating nurse will lead the section about the surgical procedure. What are you doing? What special instruments do you need, et cetera, so on and so forth. The perfusionist will then speak up and say, I want to use this cannula, we're going to go to this temperature, we're going to have such and such a flow, et cetera, so on and so forth. So people are speaking up before the operation even begins. And they're engaged. At least that's the intent of this, is to engage everyone. And it's done in a participatory manner. The big red machine, so that's what we call cardiac surgery at the MGH, the big red machine. We have a dry erase board in the hall there, and we have turned over management of the operating rooms to the circulating nurse, or to the nurse, the floor nurse that's in charge that day, the charge nurse, and to an anesthesiologist of the day. And that pair will tell me, no, you're not following yourself in room 46. We're going to put D'Alessandro's case in to follow yours, and then you're going to follow Robbie in 47. Why? Because they've figured out that's the best way to get the work done. So we've relinquished control, and again, I think that that's an artifact that demonstrates we're all collectively problem solving. Artifacts. What's the culture we need? If I talk about community and collaboration, I think community is caring. I think it's mutual respect, appropriate conduct, citizenship. So that's how I spend a fair bit of my time talking with surgeons about appropriate conduct. I think Kenny might have some of those conversations with people that I'm not party to. Collaboration, it means engagement, it means communication, shared responsibility, and synergy in problem solving. Or as Kenny might say, I think, professionalism. And the thing that I think I've learned most from Kenny, and observing the way Kenny manages the perfusion group, is his insistence on a standard of professionalism. And I think that all of us should think about that. I have more issues as a chief of the cardiac surgical group about professional conduct of the surgeons than I'd like to have. And Kenny, I suspect, has those conversations in his office as well. We're not perfect. I'm not claiming that we are. But I think we have our eye on the ball, and we're doing the best we can to make things better every day. So that's where I would close, and I'd be happy to answer any questions if you've got them, or afterwards, or at lunch, or whatever. Thanks.
Thanks.
Is that gonna work?
Oh, that's working. Sorry, my apologies. Just while, Donnie, would you like to start off?
Donnie, you're going to defend
I'm not going to defend Kenny at all. No, so I'm Donnie Lukoski from the University of Michigan. Thank you for your continued insight and focus on trying to have us all be better. I have a question around structure. And at the University of Michigan, I think we have statements that don't necessarily jive with what I think we should. think the statement something like leaders in the best. Well, it's not about an individual leader. We all can lead.
Yeah.
And so I think that our motto, I think, is flawed in some respect. It has aspirational goals, but I think it's flawed. But also the arcane system of medical school departments, where like in our institution, I believe, and David Sturmer can correct me if I'm wrong, but perfusion reports up to OR nursing. And then we have a cardiac surgery department. We have operative PAs who are in our department, but we're not all, we may live within the environment of a cardiovascular center, but I wonder if you could speak to how the structure then contributes to the fact that we're not achieving our aspirational goals of teaming.
Yeah. Well, I think you've said it, that kind of structure is not aligned around the patients. Interestingly, we're in the midst of trying to go to an institute structure at MGB because the MG and the B can't get along. We've been at each other's throats for 200 years, and so the solution is to break down the departments. They're going to be single departments, and there's going to be a heart institute, and I'm going to strongly argue that all of the bits that go into delivering cardiac care all need to be within that institute. That's the way you've got to align the incentives, right? So we'll see how far that goes. Nursing is always a challenge for a variety of reasons that are beyond our discussion here, I suppose. But certainly, I think cardiac anesthesia belongs in the same tent. Perfusion belongs in the same tent. Cardiac intensivists, right? There are places with all kinds of different models for intensive care. We have heart center intensivists. We don't have a CCU and a cardiac surgical ICU. We have a heart center ICU, and it is staffed by heart center intensivists. Some are cardiac anesthesiologists, some are cardiologists, a couple of surgeons, a few emergency department docs. There's a pulmonologist in the group, a diverse group of people, but they are heart center intensivists. And so that structural change, maybe that's an example of just what you're talking about, that structural change as opposed to it being part of pulmonary critical care or the Department of Anesthesia, that structural change has had a huge positive impact for us. And we don't talk about open and closed units and any of that kind of stuff. I think we've got that nut cracked. So structure can mean a lot.
Hi, Dr. Sundt, Dave Fitzgerald, MUSC. First of all, thank you so much.
He's calling me Dr. Sundt now. Fortunately, last night it was Tor, so that's good. After a couple drinks.
Just a couple drinks. Well, first and foremost, thank you so much for being here and sharing your experience. And I will tell you that we did text Nick while you were presenting, letting him know that you're still dunking on him for a pro-con debate 10 years ago. And he has informed us that he's ready for a rematch. This time you got to keep your clothes on.
I took my jacket off. It was a bit of theater, but...
I wonder if you can share your experience or talk to us a little bit about what teaming looks like outside of the operating room. You have at MGH, you've really served as a model for what teaming looks like inside the operating room with the way in which you communicate, the tools that you have available to help inform and make sure that teammates have a shared mental model with what to expect. What does that look like outside of the operating room? Yep. Are there activities that you can suggest for the rest of us?
Yeah, probably the easiest place to talk about is at Mortality and Morbidity Conference. And I've got an example from just this week, attending a Mortality and Morbidity Conference at another institution where there was a case presented where the suspicion is that the venous drainage was inadequate, the perfusion was inadequate, there was early hepatic dysfunction, and ultimately the patient passed. And at no point was the perfusion record even mentioned. We very intentionally let Kenny know what cases are being presented at M&M. He always knows which cases are being presented at M&M. He and Chris may review which cases they need to go into the record. But if we need to go into the perfusion record, they're ready and able to do so. And I think that conducting, when you do things like that, that's another artifact of bringing the team together. We always, I hope, often, maybe might be more honest, we hope we often engage the intensivists. How often at a mortality and morbidity conference will you hear presented a patient who made it out of the operating room but had a long course and died, and the surgeons talk about it and never even ask a mention from the intensivist. So we ask the intensivist to engage. So that's one example.
Tor, you mentioned during your presentation about the recognition that in not all environments is it easy to speak up.
Yeah.
And I was wondering whether you could perhaps just take us a little bit deeper into how you perceive the teams that it is difficult to speak up. How can we evoke change as a perfusion community effectively from the bottom up?
Yeah, it's not easy, and I don't pretend that it would be. I think that again, Kenny demands professionalism, and I hope that his group, those who are here, will, I hope, tell you that at lunch that I'm not lying. That if he feels that there's a lack of professionalism from one of the surgeons, he'll come and talk to me about it. And I hope that his perfusionists expect to be treated in a professional manner, and they certainly do behave in a professional manner. I think our perfusion group behaves very professionally. And I think that creates, and you got to go out on a limb, somebody's got to take the first step. I think that can create culture change. If you demonstrate respect and for example, ask for feedback after a case, that sooner or later that doubter will get it, that, well, maybe I should ask you for feedback too. So I think that in a subtle way, over time, it means you're taking a risk. It means you're taking, I get it. You're taking the risk, and I deal with these people, of a surgeon being dismissive of you. That's the risk you're going to take. But be a professional. It's easy for me to say, but be a professional and expect to be treated in a professional manner. Don't let them get away with that. And by don't let them get away with it, I don't mean you go scream and holler. I mean you come back the next day and behave in a professional manner. And the day after that, and you behave in a professional manner. And sooner or later, I believe, I'm an optimist, I believe that sooner or later they will get it. But you have to take a risk. And we are all leaders. I agree, we're all leaders all the time in one way, shape, or form. And that's the way you can lead somebody who's positionally in a higher than you are in the hierarchy. It doesn't mean that they're of more value than you are. Is that fair?
Oh, look, I think it's an area that is just such a difficult one for many in our community to address.
Yeah.
We have so many different structures. We hear, we have the employed groups, we have the contract groups, we have the travelling groups, and often they overlay in the same institutions. So that whole development of respect and professionalism can be, you can have two different cultures working within the same, the same unit. So, it's just a big area that requires a lot of, as you've pointed out, a lot of repetitive reinforcement of a behavioural pattern to try and bridge that, the way that the relationships are built.
So what would happen if you said, as a perfusion group, we're going to institute a checklist for going on and coming off bypass, period. You can do it. Now, the surgeon may disagree about whether it's out loud. Talk to the anesthesiologist then. But the surgeon cannot go on pump without you. You're the one that turns the knob, right? They actually can't go on bypass without you. And they can't come off bypass without you. I'm not comfortable going on bypass until I've done my checklist. Oh, Rob, you're just, like, come on, how hard can this be? Thick skin, I'm not comfortable going on bypass without doing the checklist. Period. They can't go on bypass, they can't come off bypass without you. It's no fun to have somebody, make fun of you. And like I said, the way I grew up, it was perfusionists should be seen and not heard. It's only 4 things: up, down, on, off. That's it. That's all I want to hear from you. Those were my role models. So I'm not naive to what you're up against, but you could do that.
Well, I mean, I think one of the really interesting areas for all of us was when the AMSEC standards and guidelines brought up the cardiotomy suction and the relationship to protamine administration. It gave everyone an opportunity to be talking up about a part of the procedure, and I think that would be something that people can leverage that experience to work out and help build that relationship.
Yeah. I hope my perfusionists complain to me when I need to give more cardioplegia. The heart's, I see activity and I ignore them. There's activity. Wake up. There's activity. Would you like to give? Actually, there's a joke, right? It's who's here from my place. Call Kenny Shan and let him know I'm giving cardioplegia down the right coronary artery, okay? So Kenny is obsessed with giving plegia down the right if you're administering your retrograde, right? And if Kenny's in the room and I've just given a dose retrograde, he'll speak up and he'll say, what do you think about giving some down the right? So now every time I give plegia down the right, I tell him, call Kenny Shan and give 200 down the right. It's a joke, right? But that's to me, that's collaboration, that's teamwork. And Kenny, because I'm focused on the procedure and I'm losing track of when the last time was I gave plegia down the right. So you can there are times you can tell the surgeon what the delivered oxygen is, the DO2. They may ignore you. They may say, "What is that?" Just keep telling them. What's the worst they can do? Make fun of you? Is that really so bad? I mean, really. So be professionals. That's the Kenny Shan message, I think. Be professional. Thanks. Oh, is another?
Sorry, you've got
I want to be respectful of your lunch.
Scott, do we have any questions online? Scott?
Yeah, we've got, actually we do have one question. Wrote in and asked, how do you get a surgeon to buy into a system where they have to relinquish control when they aren't interested in this from the start?
Yeah.
And I think, we kind of...
Yeah, I think that's I think that it's about demonstrating the power of teamwork. And sooner or later, behave in a manner that you think is the environment you want to be in, have a thick skin, and the young surgeons will appreciate it.
Hi, I'm Matt from Children's Wisconsin. This is such a thought-provoking, like we could talk about this all day. But recently, we had this kind of a line in the sand meeting at our institution where we literally just stopped, had no surgery scheduled. Everybody from the whole surgery organization came to the room, and we had this talk about the culture. It was more around the culture of safety, but really the same thing. Like, you should be able to say something when something's wrong. What they did in this meeting was the most brilliant thing I've ever seen. They found an articulate, somebody that was willing and articulate patient family to speak at that meeting. And it was like tear jerking. And now this is Pete, so you always get a little tear jerked, but he talked about his daughter and their expectations of what is going on in the room. And really his overall point was I need you people to be acting like this, because I don't know what the hell is going on there. And we've talked about that many times, but to have that person stand up in front of all of us and do that was an unbelievable, powerful situation. And
Wow.
if you could do it, at a hospital, any hospital, would, I think it would be really effective.
Wow. Isn't it amazing that this is a challenge for us? I mean, this is nuts. We're talking about healthcare. We're talking about taking care of patients. I mean, it's just crazy that we've evolved this way. It really is crazy. It's nuts.
We'll take one more question.
Yes, thank you, Luc Bui. Well, you just kind of started my question, like, it's crazy, why isn't this the norm? Why isn't this how healthcare leaders are taught? So, and how can we, as perfusionists, who are part of this community, how can we leverage that to the norm?
Yeah, I mean, I think there's a, I think in terms of history, oftentimes, there's a historical evolution of this. So, and I'm not trying to defend the behavior of surgeons today, but I'm trying to, to reflect. Certainly, when I was an intern, I was told, trust no one, right? You had to do everything yourself. Trust no one. You check all the labs yourself. You look at all the wounds yourself. You make sure everybody's tucked in. Trust no one. I was actively taught that. You remember when cardiac surgery was born, with a picture of Jerry Austin, when he started surgery, the mortality rate was 50%, 50%. John Gibbon bumped off 3 out of the 4 patients that he operated on, and that's why he never did heart surgery again, right? So maybe there's some sort of an inherited PTSD from those days or something like that. I don't know. People, I mean, what kind of human being, right, can cope with that? And I certainly feel like what I do is completely crazy. I mean, what normal human being puts another human being to sleep and cuts their chest open? I mean, that is nuts, right? It is crazy. And I go to work each day wondering if I'm going to bump somebody off. That's crazy, right? And you do too, right? You can make a perfusion error and bump somebody off. There's nobody who works in the hotel industry who worries about bumping somebody off, right? So, yeah, I think I'm imagining that there are psychological reasons that because you've got to, as a human being, have to seek to have some kind of control. It's really over your life. It's a normal human thing. And what I hope is that we can understand, again, to your theme of community and collaboration, that there's safety in the pack. We need to be like wolves, right? Safety in the pack. That's where the safety is. The safety is in the team. The best thing I can do to have a successful operation with this patient is to be sure that the team is functional. I made a mistake on Christmas Day because A, I pumped that patient's head full of air, but B, there was somebody in that room that did not feel comfortable speaking up. That is on me. So I'm not trying to stand here and say that I'm perfect and I've always had this figured out or any of this kind of stuff. I don't know if that answers your question.
Look, I think that's a really challenging place to end this.
Enjoy lunch.
I'd like you to show your appreciation for Professor Sundt.
Thanks very much.
That's great. Thank you.